So today we'll be learning about squint, and I've actually written here the tension giving chapter because a lot of students actually find squint really difficult to understand, and I too find it really difficult, but actually I'll be making it really simple for you. So before starting squint, the most important thing that we should understand is we have 4 recti and 2 obliques. So this is superior rectus, this is inferior rectus, here you have the lateral rectus, and here you have the middle rectus, right? And there are 2 obliques. So first of all, the mnemonics that we have been learning from our basics is SO4 LR6. SO4 means superior oblique is supplied by the 4th nerve and lateral rectus is supplied by the 6th nerve. Except for this, all is supplied by the 3rd nerve. So whenever there is 3rd nerve palsy, 6th nerve palsy and 4th nerve palsy, we will have squint, number 1. Number 2, whenever we talk about squint, it's very important for us to understand about the yoke muscles. Okay, it's very important for us to understand about yoke muscles. So yoke muscles rely on the principle of Herrings law. So what is Herrings law? Herrings law means, suppose these are 2 eyes. Okay, these are 2 eyes. So if you're looking at the right side, this eyeball moves here, basically the lateral rectus is contracting, and this eye moves here, the medial rectus is contracting, right? So these are 2 different muscles. They are supplied by 2 different nerves, lateral rectus by the 6th nerve and middle rectus by the 3rd nerve, but they are working in continuity, in congruation or in conjugation, and this is actually explained by Herrings law. Herrings law states that these 2 different muscles in 2 different eyes, they have a similar action to look into the right. Okay, and you have one vision, and that one vision is basically known as binocular single vision. Binocular single vision, and it's very important for us to have binocular single vision. If in case this is not accomplished, then we might have diplopia, right? And binocular single vision is not accomplished in certain diseases, which is very important for us to understand. Okay, so whenever we talk about strabismus or squint is basically an abnormality in the visual axis. Now what is this visual axis? Visual axis means basically we have 2 axes. Okay, so one is the orbital axis and other one is the visual axis. So orbital axis is actually the axis that is made by the eyeball. Suppose this is your eyeball and this is your orbit. Okay, so this eyeball makes certain angle with this orbit, right? And this is an orbital axis. Okay, and whenever we talk about visual axis is something which is made by the macula. So here you have your macula, which is basically, I have highlighted with this blue color. This is your macula, and this macula actually makes an angle, right? And that angle which is made by the macula with the orbit, this is known as a visual axis. So visual axis is the angle made by the macula with the orbit, and orbital axis means the angle made by the orbit with the eye, with the eyeball with the orbit. Okay, with orbit. Now what happens is, whenever your eye moves towards the abducted side, okay, so when the eye moves toward the abducted side, what happens is the orbital axis and the visual axis, they come into the same plane. That means they become parallel. Okay, so we can show parallel here. This is a 2D image, but just remember that suppose this is your orbital axis, and again along with that in the above field you have your visual axis. So suppose this is your orbital axis, and then again here on top of it there will be a visual axis. So they become parallel. Okay, when the eye becomes abducted. Okay, now in this abducted position, the elevation and depression of the eye is brought about by the rectus muscle. So rectus muscle are abductors, but this is actually a clinical action. But anatomically, if you understand that it is recti are adductors anatomically, so clinically the recti are abductors. Okay, so this is quite a lot difficult to understand, but just in a conclusion, just understand. I don't want to make you much more confused. Just understand clinically. If you say whenever your eye is abducted, suppose if this is my right eye and this is my left eye. Okay, so my right eye is going towards the lateral side. This is done by lateral rectus. When from here it goes above like this is brought about by superior rectus. Okay, just abducted and elevated. So this one is abducted and elevated. So this action is brought about by the superior rectus. That's it. Okay, similarly, whenever we talk about obliques, so if I am actually moving my eye towards the adducted side, and if I am moving it's up, suppose this is my eye, I move my eye towards the medial side, that is I'm adducting my eye. That means my medial rectus is working, isn't it? And I elevate my eye after looking at the medial side, and this is actually brought about by the oblique muscles. Okay, superior oblique. So as this oblique muscle has a primary action of intorsion. Okay, intorsion. Remember that with the mnemonic sin. Sin means superiors are intorters. Okay, superior are intorters, and primary action is intorsion. But the secondary action for superior oblique is it is depression. Depression. Okay. So this example which was given, this is wrong, isn't it? I'm just taking a concentration. Okay. If initially when I was saying this, if you had objected, oh my god, what is this person saying, then your concentration is 100%, because when I said this, I told you that it goes towards the medial side and it goes up. The work is of superior oblique, and you should have an objection. It's not superior oblique. It is inferior oblique. Exactly, it's inferior oblique, because when you adduct your eye and move up, this action is brought about by inferior oblique. When you adduct your eye and go down, this action is brought about by superior oblique. When you abduct means going towards the lateral side. This is a lateral side, this is a medial side. When you abduct and look up, this is brought by superior rectus. When you abduct and go down, this is brought about by inferior rectus. Okay, so superior rectus and inferior oblique are responsible for upward movement of your eye, and superior oblique and inferior rectus they are responsible for depressing your eyeball. Okay, center is there because all the muscles are actually having a single action. When this is contracting, this must relax. When this is contracting, this must relax. And this contraction and relaxation which I am talking about in the same eye, this is known as Sherington's law. So there are two laws, Herrings law and Sherington's law. So this was all about the basics of squint. So now let's go to the squint proper. In the squint, you need to understand that there is concomitant squint and there is inconcomitant squint. Inconcomitant, okay, and concomitant. So what is this concomitant squint? Concomitant squint means any squint where the primary deviation is equal to the secondary deviation. So what does this mean? This means that suppose this is your eye, this is your eye, this is your eyeball, okay, this is your eye and this is your eyeball. So whenever this eye, suppose let's say that this eye is squinted like this, okay, this eye is squinted like this, so here it is a esotropia. So when it comes towards your nasal side, it is actually eso. So remember NOSE, this SOS, just flip it off, it's S, So eso means coming to the nasal side, okay. Exo means it's going to the temporal side or towards your lateral side, okay. So this eye is actually having an eso. So this eye is having an eso. So suppose if I cover this eye with some cover, so I go and just I cover this normal eye with a cover. I just cover this normal eye with a cover. What happens is this ezoed eye will actually come to a center. This will actually move to a center. Okay, this a squinted eye will actually move towards the center. Okay, but what happens whenever I remove this cover? This squinted eye which had come to the center will again go back to its normal position towards the ezoed eye, and this eye, what happens is whenever this takes the center, this will actually go inside here. But inside the cover, how to see? You are not able to see. That means when you just remove the cover, this eye which was coming towards the center will actually go here, and this eye which was actually I think I'm making it confusing. Okay, just understand that there are two phobias. This is your left eye, this is your right eye. Okay, suppose now left eye phobia, when it focuses on one object, the right eye slips. When the right eye phobia focuses on one object, the left eye slips. Actually the squinted eye is the left eye. The left eye is squinted. That means if you put a cover on the normal right eye, the squinted eye phobia becomes active, and this looks okay, and here the phobia becomes inactive. And when you just remove this cover in the normal eye, the phobia of this normal eye becomes active and this becomes inactive. That is why there is no diplopia. There is no diplopia in concomitant squint. But in inconcomitant squint, there will be diplopia. Why there will be diplopia? Because Inconcomitant squint means there is a paralytic squint. This is a paralytic squint. That means suppose this is your eye, this is your eye, inside you, here you have your eye. Okay. So what happens is there are these muscles, right? Medial rectus, lateral rectus, superior rectus, inferior rectus. Medial rectus, lateral rectus, superior rectus, inferior rectus. Now what happens is, suppose if my sixth nerve is palsied, suppose this is palsied, okay, then what happens, if this nerve is palsied, there is a palsy of this muscle, then this will be lax, so there will be pulling action of the medial rectus and it will be esotropia. Okay, it will be esotropia. And what happens is, whenever you put a cover in your normal eye, now if I put my cover in the normal eye, what happens is, the eye wants to take center, the brain wants to actually take the center. So brain access this esod eye to come into the center. But what happens is, there is a muscle palsy. This cannot work. That means the lateral rectus cannot work. Okay, so if the lateral rectus cannot work, how will the eye come to the center? Isn't it? So what happens is, your brain continuously sends stimulus to this lateral rectus. And similarly, from the yoke muscle concept, we have to understand that when the lateral rectus is being stimulated by the brain, in this eye, in this particular eye, the medial rectus will be stimulated. So the medial rectus will actually come inside. Okay, so here in this eye it will be eso. This eye was already eso. While opening the cover, what you will see is, this eye is moving, the normal eye is moving. Okay, when you just remove the cover, the eye will come from this esod side to the normal side. This eye is normal, it is absolutely normal. The palsy is only in this particular eye, but the thing is the concept of yoke muscles. So in this type of squint, in the inconcomitant squint, there will be diplopia. Okay, and one more thing that I want to say you, abnormal retinal correspondence is very important. Okay, what do you mean by abnormal retinal correspondence? Abnormal retinal correspondence means ARC. This means whenever one eye's fovea work, the squinted eye fovea sleeps, right? Because of this mechanism, there is no diplopia, isn't it? This concept is known as abnormal retinal correspondence. Okay, and remember one more thing, extra thing. This concomitant squint is divided into esotropia and exotropia. And what is this tropia? I'm saying you, in a vague term, squint is divided into latent squint and manifest squint. Remember LP. Latent squint is phoreas. Manifest squint means tropias. Tropia means it is actually seen. Manifest squint means if the person comes to the OPD, you can see that his eye is deviated towards this side or towards that side. Okay, that's manifest squint. Latent squint means you are not able to see the squinted eye. For example, if a person focuses on a particular substance for a long period of time, due to severe accommodation, you will have ESO. But when he goes outside, when he sees the nature, when he goes and outside and plays, his ESO will actually disappear and he will be able to see a normal eye. This is known as latent squint. The person when enters the OPD, he will have a normal eye, but he complains that I am having squinted eye sometimes. That means his eye is going under severe accommodation when he studies or when he just focuses on a single object for a prolonged period of time. So concomitant squint, again squint is divided into concomitant and inconcomitant. This was one type of classification, this is second type of classification. Concomitant squint is further divided into ESO and EXO, and this esotropia is further divided into infantile esotropia, infantile accommodative and infantile refractive and non-refractive. Infantile esotropia means also congenital esotropia. Okay, congenital esotropia. So what will happen in congenital and infantile esotropia? The thing is, it manifests by 6 months of age, and binocular single vision is actually obtained by the age of 6 to 7 years. Okay, so person comes to your OPD at 6 months of age. Okay, he brings the child to your OPD, and that child has ESO. Will you go for surgery at the age of 6 to 7 months? No. Okay, what you will do is you will actually patch this normal eye so that there won't be amblyopia. Amblyopia means lazy eyes. Okay, lazy eyes. That means if continuously your one eye or the normal eye is looking at some object, okay, the fovea of this eye will forget to look, and this will be actually amblyopic. Okay, this will forget to see also. That is why you will just keep an eye, will keep a patch in this eye. Okay, but the thing is, when to do surgery? Surgery must be done before 6 years of age, 6 to 7 years of age. Because if he obtains binocular single vision and you do surgery, there is no use of doing a surgery, opting for a surgery. And we don't want amblyopia also to happen. So the best time will be 3 to 4 years. Okay, 3 to 4 years, just go for surgery. And what are the surgeries that you'll opt for? So you'll go for recession. There's something known as economic recession, right? Or you can go for resection. This means R and R surgery. Okay, so that means if a muscle is overacting, what you'll do is you will cut it. You will actually, suppose if this muscle is overacting, you will insert this muscle slightly backwards. This muscle is overacting, just insert it slightly backward. This is known as recession. And resection means if a muscle is palsied, you just cut it and stitch it. This is known as resection. For example, person is having ESO. Okay, this is medial side, this is lateral side. This is a medial rectus here. Yeah, you have a lateral rectus. So your medial rectus is working too much. So you just cut the medial rectus and you stitch it off. And lateral rectus, it's working. It's having like a palsy, right? There's a lateral rectus palsy. So what you'll do is you will. I'm sorry. Okay. So here the medial rectus is acting so much. No, the medial rectus is acting so much. So what you'll do is you'll actually suppose if the medial rectus is inserting here, you'll actually insert it slightly backwards. So here this is a recession, and here towards the lateral rectus it's working very lazily, right? Lazy. It's very tired. It's palsied. So what you'll do is you'll just cut and stitch. Okay. So this was about infantile esotropia, and the classical feature which you should not forget is in infantile esotropia. What will happen is in infantile esotropia you'll have cross fixation on lateral gaze. That means if you look to your right, you use your left eyes. Next is latent nystagmus. What does this means? So if you close one eye, the other eye will have nystagmus, but normally the eye will not have nystagmus. Okay. And next point it has is cross fixation on lateral gaze, latent nystagmus, and this infantile esotropia, as I already told you, 6 to 7 months of age. It is shown. Okay. Next is refractive, non-refractive. Okay, so actually this infantile accommodative. Okay, this will be accommodative and this will be non-accommodative. So accommodative esotropia is further divided into accommodative is divided into refractive and non-refractive. Okay, refractive means in case of high hypermetropia, there will be squint. So what will happen over here? Okay, this is very difficult to understand, right? Squint is itself very difficult. Okay, so high hypermetropia, what happens is there will be squint. If the child wears his glasses for a prolonged period of time, just opens it whenever he's sleeping, the squint will disappear by its own. Okay. And what about non-refractive? Non-refractive is because of high AC by A ratio. That means for very small needed accommodation, the brain is accommodating too much. So what does this mean? Okay, I'll tell you, I'll explain it, don't worry. So accommodative convergence by accommodation ratio, this increases. That means suppose I am looking something from 5 meter, okay, I bring this object to 1 meter, 1 and 20 centimeters suppose. So your eye will be towards the medial side, it will converge, isn't it? But when I bring this from 5 meter to 3 meter, your eye is converging. That means for a very little area, so it should have started to converge when it comes at 1 meter, and then 20 centimeter it will totally converge and be a ISO. This is a normal ISO, right? But whenever your eye has a EC by E ratio too high, what happens is it will converge before it comes to the before it actually has to be accommodated. Okay, so this means it has a high EC by E ratio, and the treatment for this is go for treatment with ecothyphate or give a myotic. Okay, so I'll end this video here. Just like, share, subscribe, and I'll upload more video on squint. Okay, so that will be easy.